Hello everyone, this is your host Mahek Shah and welcome to a new episode of the Heart Success Podcast where we discuss practical knowledge and the latest in the field of cardiovascular medicine. All listeners be advised that the podcast is for personal information, education, and entertainment only. Information from this podcast should not be used as medical dictum, and all decisions related to patient care should be made in consultation with care providers.
We're going to do a diabetic series where we actually go over some of the newer and older diabetic drugs, the benefits, harms, go over some of the newer drugs, especially considering we have cardiovascular outcome data for these drugs, and more importantly, start talking about how, as cardiologists, as primary care providers, we can start getting more comfortable with the newer drugs and prescribing them, especially the SGLT2 inhibitors, which now have data coming out from heart failure trials, even among patients without diabetes. The plan for this series for overlap between cardiovascular disease and diabetic disease requires really multidisciplinary action and expertise from endocrinology, expertise from heart failure, cardiovascular disease specialists, from pharmacists. And with that in mind, we decided to go and interview people from different specialties to talk about these drugs so they could share their experience and their knowledge with us. I thought it would be simpler if the first episode we created just went over what medications we're going to talk about, familiarize our listeners with the different classes of medications. And I haven't really read the mechanism of action of some of these older drugs since I left medical school. So I feel like it would be a good refresher for everybody involved in the care of patients with diabetes. To start off our episode today, we have Ilya Danelich. Ilya is a PharmD. He's a board-certified pharmacotherapy specialist. He's a board-certified cardiology pharmacist who graduated from the University of Minnesota College of Pharmacy, following which he did 2 years of residency at UNC Chapel Hill in North Carolina. Following that, Ilya worked at the Mayo Clinic for close to 4 years before he moved to Philadelphia. In Philadelphia, he is the clinical pharmacy coordinator in the Department of Pharmacy at Thomas Jefferson University Hospital. He also holds the position for cardiology clinical pharmacy specialist and works with the Advanced Heart Failure and Cardiac Transplant Division. Ilya is very closely involved in several studies around improvement in heart failure and cardiac transplantation care at Thomas Jefferson University Hospital. Ilya is actually going to go into some of the mechanisms of action for diabetic drugs, go into some more pearls and details that are clinically relevant, especially with the SGLT2 inhibitor, because in the future, cardiologists are going to have to prescribe these drugs. So a few tidbits, a few pointers on these medications. Ilya, why don't you tell us a little bit about you?
Hi, Mahak. Thank you so much for having the opportunity to talk about diabetes medications today. The things that I'm interested in, I would say professionally, would be how can we improve outcomes of our acute decompensated heart failure patients? So we're always looking at research ideas to be able to answer the question of how can we improve the lives of our patients with acute heart failure. Outside of professional interests, I enjoy basketball, both playing and watching basketball, as well as traveling and spending time with family.
Welcome, Ilya. So, our conversation today is going to really go into diabetic drugs. Ilya, why don't we start with Metformin? And you could tell us how Metformin works, and if you have any additional pearls or pointers.
Sure. So as we know, Metformin belongs to the biguanide class of diabetes medicines, and it's certainly the first-line oral drug of choice in the management of type 2 diabetes. Now, Metformin has been associated with several mechanisms of action. The primary mechanism is that it decreases hepatic glucose production or gluconeogenesis through complex effects in the mitochondrial enzyme. We know that metformin improves insulin sensitivity and delays glucose absorption in the gut to some extent. Now, in addition to all that, there's also some evidence to suggest that metformin works on the PPAR alpha pathway, which has been associated with both lowering of the plasma lipid levels as well as prevention of cardiovascular disease. In terms of additional pearls or pointers, what I would say is that metformin is generally safe. It has an excellent safety profile. There will be some patients who will experience some GI issues. Outside of that, rarely metformin has been associated with the development of lactic acidosis, but this is mainly in those patients who have severe kidney dysfunction. So I would say it is reasonable to use metformin in patients with diabetes at risk of or who have established heart failure. Now, in folks who present with conditions associated with lactic acidosis, certainly such as cardiogenic shock, that would be a time to consider stopping metformin. Now, another potential issue that we have encountered and something to be aware of is the reduction in metformin's efficacy as the severity of diabetes progresses. So metformin is highly efficient when there's adequate insulin production, but as the diabetes progresses, the beta cells begin to fail, resulting in the type 1 phenotype, and that's where metformin begins to lose its efficacy. And finally, in terms of metformin, I would say we have to be careful in that it can cause vitamin B12 and folic acid deficiency. So we have to be mindful of that and monitor those parameters, especially in our elderly patients.
That was great, Ilya, and that was very informational. One of the other classes of drugs that we commonly encounter in our patients, cardiovascular patients with diabetes, is sulfonylureas. You could tell us how sulfonylureas work and if there's something to watch out for this class of drugs.
Great question. So sulfonylureas certainly are used very commonly in today's day and age. And what we know about sulfonylureas is that they work to decrease glucose levels by stimulating the pancreatic beta cells to increase insulin release. And in addition, and although this doesn't really happen to a large degree, the sulfonylureas do improve insulin sensitivity by upregulating insulin receptors and suppressing excess hepatic glucose production. We also know that sulfonylureas decrease the breakdown of lipids to fatty acids, and they reduce the clearance of insulin in the liver. Now, just a couple things to keep in mind, so that there are actually two groups of sulfonylureas. There are the first generation agents, which include chlorpropamide, tolizimide, and tolbutamide. And we also have the second generation agents, which we're probably more familiar with, and those include the glipizide, glimepiride, and glyburide. Now, the first generation sulfonylureas are known to have longer half-lives, higher risk of hypoglycemia, and a slower onset of action as compared to the second generation medication. So for these reasons, second generation agents are typically used in clinical practice. Now, just a couple more pearls and pointers to keep in mind. This class is contraindicated in patients with hepatic and renal disease, and also contraindicated in patients who are pregnant due to the possible prolonged hypoglycemic effect that can be seen in infants.
Thanks for that, Ilya. I have not been watching out for those first generation sulfonylureas. To repeat, those were chlorpropamide, tolzamide, and tolbutamide, because I believe if I start seeing those drugs, I may ask the primary care doctor to probably consider second generation, which may be safer. That brings us to the next class of drugs, which we don't see anymore because of concerns with heart failure, I guess, and some of the other cardiovascular issues, which we go into details later with our endocrinologist as well. But could you describe the thiazolidinediones for us, what they do and what our concerns are with this class of drugs?
Absolutely. So I'm just going to refer to them as TZDs to make things simpler.
Sense. Yeah, it's better.
So these agents, which are comprised of both rosiglitazone and pioglitazone, basically improve insulin action. So they serve as PPAR agonists, and they facilitate increased glucose uptake in numerous tissues, including the adipose, muscle, and liver tissue. Now, this class has been associated with a reduction of free fatty acid accumulation, as well as a reduction in inflammatory cytokines, rising adiponectin levels, and preservation of beta cell integrity and function, all leading to improvement of insulin resistance and beta cell exhaustion. Now, in addition to that, they have been associated with inhibition of hepatic gluconeogenesis.
The next class of drugs, we're moving on to some of the newer drugs. A lot of these names may sound familiar to you because you may be seeing these on your patients, diabetic patients, drugs like liraglutide or semaglutide, basically ending in glutide. These are the GLP-1 agonists. They clearly have recent excellent cardiovascular outcome trials showing some benefit when it comes to cardiovascular disease and major adverse event benefit. So could you tell us how these drugs work and how these drugs are actually given?
Absolutely. So I think as those of us who practice clinically and take care of our patients with cardiovascular disease who also have diabetes, we're starting to see more and more patients who are on these medicines. So the GLP-1 receptor agonists includes a number of medications now, including dulaglutide, exenatide, liraglutide, lixisenatide, and semaglutide, as well as albiglutide. So as Mahek pointed out, they all end in glutide. And how do these medications actually work? So they stimulate the glucose-dependent insulin release with a low risk of developing hypoglycemia. And we also know that glucagon-like peptide is a natural occurring incretin hormone. It is secreted by the L cells of the intestine in response to food ingestion and binds to the G protein-linked receptors expressed on the islet beta cell. Now, importantly, this class of medications is associated with a number of secondary effects, including increase in plasma insulin, inhibition of glucagon secretion, a delay in gastric emptying, a decrease in appetite, an increase in satiety, all of which results in a weight loss of about 2 to 4 kilograms, as well as an increase in beta cell mass, lifespan, and differentiation. Now, importantly, the GLP-1 agonists are administered subcutaneously rather than through the oral route of administration. So that's something to keep in mind and make sure that a discussion is had with both the patient and the provider before these are prescribed.
Thanks, Ilya. That was great. Great summary of the GLP-1 agonists. And there's another class of medications called the DPP-4 inhibitors. They're the dipeptidyl peptidase 4 inhibitors. Could you tell us maybe how this class of drugs work?
So the DPP-4 inhibitors are actually somewhat related to the glucagon-like peptide. And the DPP-4 enzyme, it's actually an enzyme that is involved in the rapid degradation of GLP-1. And thus the effects of the incretin system are actually enhanced by inhibition of DPP-4. Now, this class includes medications that mostly end in leptin, so including allogliptin, linagliptin, saxagliptin, and sitagliptin. And the other point to keep in mind is that these medications mostly impact the postprandial levels.
So the GLP-1 agonists are the glutides, and looks like the DPP-4 inhibitors are the ones that end in leptins or gliptins you mentioned. That brings us to the SGLT2 inhibitors. These are the sodium glucose cotransporter inhibitors. And we'll spend a little more time on these drugs because our expectation is, like we said, that cardiovascular providers will start prescribing these medications. So Ilya, maybe you could tell us about how these drugs work and then go over some of the individual drugs and aspects that we need to watch out for when we go about prescribing these medications. In cardiovascular patients, in heart failure patients, maybe with or without diabetes, honestly, at this point, based on the data we have.
Yeah, Mahek, this is a very exciting time in the heart failure world, both in patients with diabetes and those patients without diabetes, because we have a new class of medications that has been shown to have impressive clinical outcome data. This class includes 3 medications thus far: empagliflozin, dapagliflozin, and canagliflozin. And in terms of the mechanism of action, from a glucose standpoint, the SGLT2 inhibitors provide insulin-independent glucose lowering by blocking glucose reabsorption in the proximal renal tubule by inhibiting SGLT2. Now, this effect is more pronounced in the setting of hyperglycemia, where significant amounts of glucose are filtered into the urine. Now, glucosuria diminishes significantly as the blood glucose normalizes. Now, what's interesting and what has a lot of people befuddled a little bit is how does it actually work to decrease and improve clinical outcomes in patients with heart failure? And although there have been a lot of hypotheses out there, including a diuretic response, a blood pressure response, afterload reduction, and so forth, what we know now is that the way they improve cardiovascular outcomes has yet to be elucidated. Now, beyond their effects on blood glucose, as I mentioned before, the SGLT2 inhibitors also cause diuretic and natriuretic effects, including weight loss and lowering of the blood pressure on average of about 3 millimeters of mercury. The other piece, because these are new medications to sort of go over, would be the dosing of all of these agents. Empagliflozin is typically dosed at 10 milligrams a day, but it can certainly be increased to 25 milligrams daily if you need to achieve your glycemic goals. Now, this medication should certainly be avoided in patients with a GFR of less than 45. Canagliflozin is typically started at 100 milligrams a day, but can certainly be increased to 300 milligrams a day if needed to achieve glycemic goals in those who have a GFR of greater than 60. Now, it should be avoided in patients with a GFR of less than 45. And in those between 45 and 59, the dose should not exceed 100 milligrams per day. Now, the third agent in this class, dapagliflozin, is dosed at 10 milligrams a day, but certainly one can reduce it to 5 milligrams a day or consider it to stop the therapy altogether if there is an acute or unexpected decline in the patient's kidney function, or there's concern for volume depletion or hypotension. And then one can consider either resuming the medicine later on or to completely or to go back to the previous dose. Now, if possible, it should be avoided in patients with a GFR of less than 30. Now, one thing to keep in mind in terms of this whole kidney function is that SGLT2 inhibitors doses are modified in patients with impaired renal function because the medications tend to be less effective in lowering glucose concentrations when renal function is impaired. Now, the cardiovascular benefit of these medications appears to be present down to a GFR of about 30. I guess the other big thing that I want to discuss today, Mahek, are the things to consider when prescribing an SGLT2 inhibitor. What are the things that prescribers should be monitoring when they start these medications? I guess a couple of things to keep in mind. I would say first, providers should consider checking kidney function in the first several weeks of therapy, and that's for several reasons. One is that a diuretic effect may be observed with SGLT2 inhibitors and potentially additive natriuretic effects when SGLT2 inhibitors are combined with loop diuretics. So for this reason, it may be necessary to reduce the diuretic dose or regimen in those patients who are taking loop diuretics. Related to this, patients on diuretic therapy should be educated to monitor for signs of volume depletion, such as orthostatic lightheadedness, and to contact their healthcare provider should these occur. Now, in addition to that, we've talked a little bit about the role of kidney function. What we know from some of the data that has recently come out is that this class has been associated with longer-term nephroprotective effects. But with that said, in the acute setting, a modest decrease in the GFR may occur. So it's important to keep that in mind, that initially the GFR may fall, but then later on you will have nephroprotective effects. So for all of these reasons, it's reasonable to consider checking the patient's basic metabolic panel in the first few weeks after starting this therapy. Now, a couple of other things to keep in mind. Patients who start this class of medications should be informed about the higher risk of genital mycotic infections and that this risk could be lowered with meticulous attention to personal hygiene. In addition to that, there is a little bit of a risk of developing euglycemic DKA, and patients should be informed about this risk and also be advised to seek immediate care if they develop symptoms associated with DKA. So things like nausea, vomiting, abdominal pain, weakness, and so forth.
Let me break just for a second to explain this concept of euglycemic diabetic ketoacidosis that is somewhat unique to this class of medications. SGLT2 inhibitors have been associated with the development of euglycemic diabetic ketoacidosis. These are patients with really normal glycemia that have diabetic ketoacidosis. One of the mechanisms attributed to this is the fact that SGLT2 inhibitors increase urinary glucose excretion. That's how they work. And they reduce insulin independent, both pre and postprandial glucose excursions. Because of what they do, they lower plasma glucose, they also lower circulating insulin levels. In addition, enhance glucagon secretion. Now, this combination of reduced insulin and elevated glucagon levels stimulates lipolysis in fat and hepatic ketogenesis, which in turn could trigger the onset of euglycemic diabetic ketoacidosis, especially under certain conditions, such as those who have insulin-dependent type 1 diabetes and type 2 diabetes that is characterized primarily by beta cell dysfunction. It has also been reported that certain patients who are taking extremely low carbohydrate diets are at higher risk for developing euglycemic diabetic ketoacidosis. So it's very careful to watch out for patients who are taking strict low carbohydrate diets because they could be at risk for developing this complication.
Back to Ilya.
Also, because of these potential effects on glucose, both from decreasing glucose and potentially causing DKA, patients should be educated to monitor their glucose at home for at least the first 4 weeks of therapy. Now, the other thing is, in terms of sugar control, because it can decrease the patient's A1C and their sugars, if the A1C of the patient is well controlled at baseline, or they're known to have a history of frequent hypoglycemic events, it is reasonable to consider reducing the dose of sulfonylurea by about 50%, or maybe to reduce the basal insulin by about 20% when starting therapy with an SGLT2 inhibitor. And finally, as I mentioned before, we know that SGLT2 inhibitors can decrease blood pressure, and what we have seen is an average of about 3 millimeters of mercury. So it's important to educate the patients regarding symptoms of low blood pressure. So things that we are always telling our patients: dizziness, lightheadedness, weakness, things of that nature. And I guess the last thing that I wanted to talk about are what are some of the patients that should not be prescribed SGLT2 inhibitors. So certainly, at this point in time, those patients who have significant chronic kidney disease. Also, and this is particularly true with canagliflozin, is those patients who have a history of prior amputation, who have severe PAD, neuropathy, or who have a history of diabetic foot ulcer. It probably should not be prescribed to patients with a history of recurrent genital infections, as well as those with a history of DKA. And again, particularly for patients on canagliflozin, it should be avoided in patients with a history of osteoporosis. So these are just, a few pearls and, things to consider when starting patients on SGLT2 inhibitors.
Now, those are great points. And like you mentioned, there's so many papers coming out these days on the use of SGLT2 inhibitors, and we're trying to educate cardiologists how to start getting more comfortable with these medications, what to start looking out for. I think it's reasonable, all the things that you just mentioned, maintaining good genital perineal hygiene, watching out for orthostatic hypotension, making sure these people are getting regular foot exams, watching out for symptoms of DKA or advising them on nausea, vomiting, or fatigue, and some of these other signs and symptoms that may be associated with DKA, and avoiding taking any excessive alcohol along with taking these drugs. I think we're going to manage these patients more and more with the help of endocrinologists and with the help of community PCPs. And I think everything that you just spoke about today was incredible. It really does give us an outline of where to begin and what to watch out for in addition within this population. So thanks a lot, Ilya, for your time. We appreciate you coming on and really educating us on this very important topic today.
Thank you, Mahak. It's been a pleasure.
Thanks, Ilya. The trials conducted among SGLT2 inhibitor drugs showed that these drugs may have a nephroprotective action. What these studies commonly used as an endpoint was changes in renal function and progression of renal function. For example, Credence looked at canagliflozin versus placebo in addition to patients who had RAS inhibitor use at a very high percentage. In this study, 99.9% had additional RAS inhibitor use, followed these patients for a mean of 2.5 years, and then looked at renal endpoints, end-stage renal disease, where end-stage renal disease is defined by need for dialysis, kidney transplantation, or a sustained reduction in estimated GFR to less than 15 ml per minute per 1.73 meters square, or it could represent doubling of the serum creatinine or death from renal causes, and it also included the risk of progression to macroalbuminuria or reduction in albuminuria as a common endpoint. And most studies in part showed that if not every single aspect of these individual endpoints, parts of it were significantly better among patients who received SGLT2 inhibitors across different drugs. That brings us to why this may be the case. The next part of the conversation, I will be briefly discussing some of the less well-known effects of SGLT2 inhibitors. These benefits are not as well understood because the mechanisms have not been clearly laid out. So part of what I describe is hypothetical. Take it with a grain of salt. We know that there is the phenomenon of diabetic kidney disease. In diabetes, hyperglycemia increases angiotensin II synthesis at the glomerular and renal proximal tubular level, which results in proximal tubular hyperplasia and hypertrophy. Hyperglycemia and tubular growth cause concomitant increase in the expression of SGLTs, with consequent higher proximal tubular reabsorption of glucose and sodium. The dependent reduction in distal sodium delivery to the macula densa determines the deactivation of the tubulo-glomerular feedback, thus allowing single nephron GFR to increase, which is basically the concept of diabetic hyperfiltration. The increase in GFR, abnormal albuminuria, and extracellular volume expansion with dependent systemic hypertension commonly lead to progressive diabetic kidney disease. So this is the hypothesis in why patients with diabetes commonly develop CKD. Now, we don't truly have a clear mechanism on how SGLT2 inhibitors affect this cycle of progression in kidney disease among patients with diabetes. Now, mechanisms have been proposed which could explain the nephroprotective effects, part of which is the glycemic control. One of the major mechanisms independent of glycemic control seems to be the restoration of normal tubuloglomerular feedback. Indeed, glomerular hyperfiltration is seen in 75% of type 1 and 40% of type 2 diabetics at the beginning of the disease. The physiologic goal of this TGF, which is the tubular glomerular feedback, is to limit salt dispersion and dependent volume depletion in the presence of high blood pressure, perfusion in the renal artery, or reduced proximal tubular reabsorption. This mechanism is constantly active, with the extent of the effect being dependent on the delivery of sodium chloride to the macula densa. So in diabetes, SGLT2 inhibitors, by limiting the abnormal reabsorption of sodium chloride in the proximal tubule, very likely restores a normal tubular glomerular feedback activity and normalizes glomerular filtration. In addition to these intrarenal hemodynamic benefits, it is proposed that it may have additional anti-inflammatory and anti-fibrotic nephroprotective effects. It may suppress the production of reactive oxygen species. It lessens glomerular sclerosis and decreases tubulointerstitial fibrosis. Another proposed effect is the improvement in muscle-specific insulin sensitivity, something that has actually been confirmed in diabetic patients treated with SGLT2 inhibitors, because part of CKD and diabetes is that CKD results in increased renin-angiotensin activation, leads to elevated levels of pro-inflammatory cytokines, increases aldosterone, increases angiotensin II levels, causes metabolic acidosis, accumulation of urea and uremic toxins, all of which promote insulin resistance. So part of it may have to do with the fact that these drugs do improve insulin sensitivity among patients with diabetes and CKD. In line with some of the benefits that we mentioned for renal disease, there is other proposed mechanisms for patients receiving SGLT2 inhibitors that have clear cardiovascular benefits. Again, these are not clearly proven in all these patients. A lot of it comes from bench research and animal research. So of course, for cardiac patients, I think part of the benefit is the improvement in your ventricular loading conditions, which is a reduction in preload because it's a natriuretic, causes osmotic diuresis, and a reduction in afterload because it improves blood pressure and possibly some improvement in vascular function. There is other proposed mechanisms which may be improvement in cardiac metabolism and bioenergetics. It inhibits myocardial sodium-hydrogen exchange. It reduces cardiac fibrosis and cardiomyocyte necrosis. And additionally, some alterations in adipokines, cytokine production, and epicardial adipose tissue mass. So the proposed mechanism for the cardiac benefit, in addition to the ones we just mentioned, are some of these other cellular mechanisms by which it supposedly benefits. We'll need more data before we can be certain how much of a role this has to play. That brings us to the end of another great episode that we had a fun time creating. We will be following up these episodes with 3 other episodes. The plan is to do 2 more episodes with endocrinologists, followed by another episode with a cardiologist who is very closely involved in SGLT2 inhibitor related research. Watch out for those episodes coming out in the next few weeks. Thank you so much for listening. If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestions for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.